I'm Mary Zatina. Welcome to Champions of Care, presented by Oakwood Healthcare. Today we're talking about knee pain and treatment options. And if medical options don't work, you may be considering total joint replacement for the knee. Today we have with us one of the foremost experts in total knee replacement. Dr. Lawrence Morawa, welcome to Champions of Care.
Thank you.
Dr. Morawa is chairman of the Orthopedics program at Wayne State University. He's also an Oakwood affiliated physician and head of the Oakwood Bone and Joint Institute. So we are very happy to have you with us.
Thank you.
Tell me, what is knee replacement and when is that surgery a good option for a patient?
Well, first of all, knee replacement becomes indicated when all non-operative modalities have failed. And Dr. Hausner talked and did a very nice coverage of that. The main reason we do total joint surgery, number one indication, is pain. And pain then leading to loss of function. And that is usually because the knee is worn out to the point where they're having bone-on-bone contact at the joint. And we can no longer treat that with medications or injections or even arthroscopic debridement that was also shown. So we're faced with either living with it or making a major surgical procedure, which total joint surgery is. What that entails, as a little model here, is we replace the two ends of the major bones. Your thigh bone or femur is replaced with a metallic device that is based on the size of the bone, and the shin bone is replaced with a metal and plastic surface. So the two surfaces now are replaced with an artificial material that then articulates to make your knee joint so that that joint that was painful and rubbing is no longer there.
So the plastic represents the meniscus and you're kind of giving us a new coating for the bone there. That's really what's happening in a
Correct.
Total knee replacement.
You're resurfacing the two major portions of the joint, and we don't have the model here, but you also have a kneecap in here, and we frequently will put a button of the plastic on the back of the kneecap that faces the joint, but we don't take out your kneecap. It's just the backside is surfaced. So there's three major pieces that are placed. And if we could show that x-ray, we could show you what it looks like on an x-ray.
There it is.
And the white material here is the metal. And this is the thigh bone here and the shin bone down here. And you see a space now. Well, that space is that plastic insert we showed. And so that has basically restored the joint surface that's been worn out, and it's nicely aligned so you have a good alignment of the joint. When the patient now has a straight leg, for example, people with arthritis frequently will end up with a bow leg or a knock knee. When we put in a total knee, we not only take care of that, but we also straighten our leg out as well, which makes ambulating easier, going up and down stairs, and main thing again, relief of pain.
The Champions of Care crew visited you actually during a procedure, and we have a videotape of that to show our viewers. Let's take a look at it.
Okay.
The purpose of the navigation system is to put a total knee in the best possible alignment we can and get the best possible range of motion we can. So what we do with the patient is when we bring them into the operating room, we put two pins into their femur, which is their thigh bone, two into their shin bone, the tibia, near their knee, and we apply what we call trackers. And on the femur, the tracker is green, and on the tibia, the tracker is blue. And that sends off an infrared signal that is picked up by a camera that we have positioned properly for patients, that information is then locked into the computer. And so wherever that patient moves in space, the computer knows where the bones are, where the joint is. We open up the wound and we surface map the end of the femur, top of the tibia, and we also do what we call a motion analysis to find the center of the femoral head. Once we do that, then we make our cuts based off of that. We also know what the initial deformity is, whether they're in a bow leg or knock knee, if they can straighten their leg or can't straighten their leg, and what their initial range of motion is. We then compare that at the end to where we are, and we like to keep it within a 3-degree window of neutral alignment, neutral being 0. And in this gentleman, he had a bow leg, and so we got him within that 3-degree window. It also helps us size the components, and then we put the best size component for this individual patient in, and then we can at the end check the alignment, we can check the range of motion, and do all of the other things to make sure what we say the knee is balanced. When we talk about getting the alignment proper, what we want to do is that 3-degree window gives us a better wear characteristics for the prosthesis itself, so that if you get him in better alignment, the knee should last longer for the patient. And I'm talking about frontal alignment, meaning if you're looking at the patient from face on. And so it's a very accurate system, and it's a big improvement. And it doesn't take significantly longer to do once you're accustomed to the system. So we finished this patient now, he's got his knee in, and I think he should do well.
That is fascinating. Dr. Morawa, tell us a little bit more about the STRYKER Navigation Suite.
Well, the navigation suite is unique in this part of the Michigan. We've have had it present for about I think 7 years now in different phases, and we actually built it into the operating room within the last few years. And we put in all our total needs with that. And the purpose of it is a number. And the first thing is obviously the patient benefits are that we can put the knees in very accurately in alignment, and that leads to better longevity of the prosthesis. And what I mean by that is, instead of lasting, in the old days we used to say they'd last 10 to 15 years, now we can pretty much say if they're put in with proper alignment with the proper bearing surface, meaning the plastic we put in to the joint, they're going to last 20 to 30 years. And what that has allowed us to do is to look at younger patients who in the past have had to suffer significantly even though their joint is worn out and they were told, oh, they're too young for a replacement. So we've moved our age grade down a bit so we can do it in younger patients, and we can say this is going to last you 20 to 30 years. Well, if you're in your 50s and you're looking at that, your activity level goes down, and so the longevity of those are much improved. And also the pain goes away, which is obviously, again, the key thing. The other big benefit for it from our standpoint is we're involved, as I stated, with Wayne State University, and we train residents. And this is a wonderful teaching tool to help residents understand how to put in a total knee properly, because we have all the measurements of where the knee is, the angles, the gap between the bones, and measure them out. So it's a wonderful teaching tool. So those doctors we're training have a significant advantage on learning how to what we call balance the knee properly when it's replaced. And so we use it in that effect because we are a teaching hospital at Heritage now with Wayne State University.
Dr. Morawa, we're going to ask you some questions about recovery after joint replacement surgery after this short break.
Thank you.